Welcome everyone to this month's and the first of 2024 pre-hospital webinars, and we're going to discuss pre-hospital analgesia, something we're all involved in delivering, probably whatever grade you are. And we'll discuss why that's the case in a minute. Let me just find where this window here is going a bit funny onto that screen. There we go, found it. So as usual, we've got the chat box open. We've also got the Q&A box open. Want to make it easier for the old and slightly weary people like myself and Andrew are. Then if you've got any questions, if you can pop them in the Q&A box, that makes them easy to find at the end, because in the chat thing, they disappear up the line and we can't find them again. So any questions you got on the way through, just pop them in there. Unless we get any sort of immediate requests for responses, we can put in the chat. So let's see where it takes us tonight in our 50 minutes of allocated time. Well, first we have to remember, sadly, after last month's webinar on ALS simulation, someone complained that they didn't agree with some of the things that I said, although I had got them out of the 𝐥𝐸 2023 guidelines, so they probably were fairly scientific. But of course, we have to remember these webinars are just my opinion, and everyone, right or wrong, is entitled to one. But just for clarity, these talks are based on the evidence available to me and as I interpret it, and I don't always think I'm always right. But obviously, it is just opinion, and you should interpret that in your own way. And it doesn't represent any organisations or companies that I may or may not work for. It's like the BBC here, isn't it? Yeah. Other CPD services are available, all that sort of thing. Excellent. So let's make our way forwards. We've got that out of the way. So the fabulous John Carey, who sits at the background of the CPDme stuff for these webinars, came to me a few months ago and said, I've got this list of requests of talks people would like. Are you willing to sort of take those on in 2024? I said, yep, go on, send it over. So like a bad wedding DJ, I'm taking on the challenge of your requests from the whole list he'd gathered in 2023, and analgesia was on that list. So here we go. So from the beginning of our knowledge of medicine, analgesia was a common theme, from the use of herbal and plant remedies, including opiates from poppies, salicins from willow bark, which was the original basis of aspirin, and atropine, or atropine as we know it now, from deadly nightshade that was originally used as analgesic. A core priority beyond life-saving interventions in pre-hospital care should really be analgesia. It's a visual and very satisfying intervention, and really both an ethical and moral imperative that we know can also provide clinical and logistical benefits. The patient can be made better by relieving pain, and it certainly makes the patient easier to manage. But in order to decide how we're going to treat pain, then we have to talk a little bit about how we measure pain. I think that's really, really important. We're going to provide analgesia. We need to measure that pain to see if our analgesia is effective and to make decisions about what analgesia is appropriate. And generally, in most services and in nearly in all documentation, we use this 0 to 10 analog scale, and that's the thing we see in most places. The trouble is, though, pain is very subjective. A teenager who's never experienced pain, so finds it very difficult to give you a score, versus Nan, who's had 4 children, 2 hip replacements following fractured neck of femurs, and lives with chronic pain. They both have a very different experience of pain, how they interpret pain, how they manage pain, and how they would describe pain to us. There's also an element of character and resilience in there. Years ago, when we used to work with professional mountain bike racers, they would race with peripheral and rib fractures if they could get enough analgesia, because they were professional riders and their sponsors expected them to ride. So, I think that's, it's important to appreciate where people are coming to us in describing their pain, and that's going to impact how we manage their pain. As a patient, you need something to anchor your pain score to in order to give it a meaningful score. And if I give you an example, if you're a reasonably experienced driver and I put you in your car and covered up the speedo so you couldn't see it, and then asked you to drive down the road at 30 miles an hour, hopefully most of you will be able to do that fairly accurately, as you're used to it, as it is the speed limit in most built-up areas, although soon becoming 20 in many places. So we're used to that. We have a experience. We have a point where we recognize we're doing approximately 30 miles an hour. And I'm sure if we did that experiment, people could get pretty close. But if I did the same thing and asked you to drive your car at 45 miles an hour, that's not a speed we ever use. It's not a speed limit. And I think people would struggle to find that really difficult. They'd be a lot less accurate. So how the patient scores pain may be biased very much by their past experience of pain and the experience of pain they've had in the past and the pain they've got now. And so pain scoring can be quite a difficult thing. So commonly you hear things like, 10 is like having your leg bitten off by a shark. The trouble is in the UK, it's probably not a likely or reliable reference point. Even in places that have large human attacking sharks, it's a pretty rare occurrence. So it's unlikely that any patient you go to has been bitten by a shark unless they've actually been bitten by a shark, and that's why you go into them. So how can someone use an example they have no experience of? How can we say to them, it hurts this much, when they've no experience of that pain? They've no way of interpreting it, how that pain would be measured. So it's very difficult for every individual. Maybe we should consider asking them about previous episodes of pain or old injuries if they have life experience like Nan, and compare it to that, better or worse. Say, when you fell and broke your hip, is this pain now better or worse than that? Yeah, is it better or worse than the pain you had then? But in younger people who've never experienced bad pain, they've no anchor point to measure that to. So they don't know where to start. Now, once in a social media discussion, amazingly one where no one said everyone else was wrong, someone said, we're discussing pain on Twitter, now known as X, and someone said a 10 out of 10 would be like the American guy who cut his own arm off with a cheap blunt multi-tool in order to rescue himself. And having once made a TV show with him some years ago, and yes, that is a much younger version of me, I added him to the conversation and he confirmed it was certainly a 10 out of 10. And he now had a good reference point for future pain measuring. Is that pain better or worse than cutting off your own arm with a blunt, rusty knife? At the end of the show, we actually gave him a cat tourniquet with his name written on the little white band in case he ever decided to cut his other arm off, which he thought was absolutely hilarious. So he obviously clearly got the aforementioned paramedic dark sense of humor. So how could we score pain better that gives us a more reliable reference to the masses who have no anchor point for their pain, who have never experienced severe pain, have never broken anything? This is the WHO pain ladder, and it's how we model which analgesia is used. So analgesia therapy is designed around mild pain, mild to moderate, or moderate to severe, effectively a 3-point system. 3 steps in the pain ladder. So I often find it much better, particularly in patients who really struggle with the 0 to 10 score, to ask them, just is their pain mild, moderate, or severe? And they cope with that much better. People are able to make an answer. Yes, it's still subjective, but that's fine. The patient's perception, not ours, is the pain that they're experiencing. And it doesn't require them necessarily to have an initial reference point, because the trouble people have with the 0 to 10 analog scale is deciding whether their pain is the top end of a 6 or the bottom end of a 7. Yeah, where is that line? You say to people, is this mild pain? Sort of thing you'd walk around with? Or is it moderate pain? You might have to hop. Or is it severe pain? You can't move. Yeah, then I think that really helps people. Yeah, and they, really find it a much better way of scoring their pain. We have other systems in place, the Wong-Baker pain rating scale for smiley faces to sad faces, for mostly for pediatrics who are withdrawn or non-verbal. I can't say I've ever used this a lot, and when I have, I can't say I've ever had much success with it. Yeah, suddenly surprise a child with, coming up with a system that they've never seen before. I'm not sure entirely works, but I'd be interested to see if anyone else has had experience with it, particularly those that spend a lot more time working with pediatrics. That would be of interest. And it gets even more complex in our non-verbal or non-communicative adults, where we may have to use visual clues and clinical experience in order to measure their pain. It's very difficult, and we may have to clinically assume the patient has a pain related to the injury. They've got a fractured femur, and yet they're sat smiling at you. Yeah, we have to maybe make a clinical assumption that actually it does hurt, and then maybe they need some analgesia. But that's very difficult. And the descriptions here is, Wong-Baker based, using the pain, using the faces, but then with descriptions as well. But it all starts to get quite complicated about how we're going to measure pain in these groups. And I think the other thing we have to consider is where you would like to be. Yeah, if you're in pain, where on this scale would you like to be? Yeah, and I think it's not uncommon to see people who have not been given enough analgesia. Yeah, we see patients that started with a high pain score, severe pain, or a 10 out of 10 if they're comfortable with that system. And they're given analgesia until it's a 6 or a 7, as if that's sort of, appropriate. And a 6 or 7 is a lot of pain. So is that appropriate if you have more analgesia within your guidelines? And I think sometimes there is a tendency to under-analgese people. And as long as there's no clinical reason or no side effects that means we shouldn't, then really we should take people down to, at the very least, mild pain. That's where people should be comfortable, isn't it? They can just feel it, but it's not bothering them anymore. Yeah, or maybe even no pain would be even nicer, wouldn't it? I think if if we took someone and repeatedly punched them in the face and then asked them how much analgesia they would like, they would probably like analgesia until the pain became mild or non-existent. Yeah. And if there's no other reason that we can't do that, then we really should make to try and get people into a comfortable place with analgesia. Investigation of the pain absolutely may be appropriate and can sometimes be a key part of our diagnostic process, can't it? Getting people to describe the pain, tell us the history of the pain. I don't think anyone minds which system you use. Yeah, there's lots of different mnemonics for pain assessment. And they all effectively interrogate the same things. They may use a formalized version or a version from experience where you change the question depending on, what the condition is or what the suspicion is. Remembering, though, of course, that the patient has not read 𝐥𝐤𝐤 or your textbook. Yeah, and so the patient won't tell you the classic signs. They'll describe it in their own words. But sometimes that can be very beneficial. Getting a patient to describe something in their words is often a very good diagnostic tool. You just have to hear what they're saying because they're not using your medical words. Yeah, but they do translate. So all these systems do the same thing, but they may be really useful. There's a number of other things we could do. In children, distraction can be a great tool. Yeah, and can be analgesic in itself. Yeah, when they stop concentrating on something, stop worrying about it. Distraction can be really good. It's just 999 Ted, who's the mascot of the ambulance service in the area that I live. And a bit like the Stig, nobody knows who 999 Ted is. We have our suspicions. Splintage is also great analgesia, isn't it? We know that. You know, we can use splintage, vac splints, traction splints, etc. And one of the key byproducts of that, as well as making it easier for the patient to move, maybe limiting hemorrhage, is analgesia in itself. On the old model of it hurts if I move it, so don't move it advice. If we're going to mobilize something and it doesn't waggle about, then it won't hurt as much. So whilst we may need some analgesia to apply a splint, it will often reduce our analgesia requirements after that, and the patient will become comfortable because the ends of the bones aren't grating together or cutting into the soft tissue. So I think we should never forget that there is other things in analgesia. But once we're through all that, then we need to think about the analgesic options that we have available to us in pre-hospital care, and what can we do. And that very much depends on the setting you're working in, the level of clinical grade you are, the system you're working in, the experience that you have of using these medications, and numerous other multifactorial things. So we're going to try and cover as many things as we can and talk about the pros and cons of different medications. So we're going to start at the easy end, oral medications. Oral medications are easy to store. If you're working in a remote place, they're small and light and don't need syringes or IV access. They're not affected by temperature that much. They're commonly cheap. They're easy to transport. They don't break. As a whole, if they're tablet form. And they can be effective, but may just take that little bit longer to work. So we should never forget that routine medicine like paracetamol, can be very effective. We widely use Calpol in pre-hospital care for pediatric analgesia. And also it's very easy to give to children because they're used to having it, because they get through a couple of tankers of it by the time they're about 5. So they're used to having it, they accept it, it's very easy to give to them. They like it. Unless, of course, your employer decides to be cheapskate and buy some off-brand Calpol, the cheapest possible stuff, which tastes absolutely vile, and you've no chance of getting the kids to take it. Generally, what they're used to is the nice tasting stuff, and you can never get them to take the cheap stuff. It's just absolutely hopeless. When I worked for the out-of-hours GPs once, we used to get told off for printing prescriptions for genuine Calpol rather than giving people the cheap stuff we had in the cupboard. And every time they complained, we just said, well, it's because the cheap stuff is pointless because they won't take it. It tastes horrid, and you can't get them to take it. So we need to use the real stuff. Other analgesia and opiates like codeine phosphate tablets, obviously cautious for long-term use. For risk in the elderly, particularly of constipation and bowel obstruction, that sort of thing. And some ambulance services, including the area I work in, have Oromorph, which can be incredibly useful in children and other times where it's difficult to get access in patients. Really, really effective. It does have some medicine control issues. If it's in big bottles, it's very hard to measure how much you've used versus how much is still in the bottle versus so on. So so you can get it in sachets, but it's phenomenally expensive. You can get it in little bottles now, which are slightly easier with the aim of disposing with what's left. But all these things can be really effective, really easy to use, obviously within the limitations of who can use them. But we should never forget sometimes the value of these things, particularly in things like Calpol in pediatrics. Possibly ibuprofen as well. We don't tend to use so much ibuprofen. If you work in different settings, like sports settings, you should be very cautious about ibuprofen. You have to remember ibuprofen is an anti-inflammatory and effectively provides pain by getting rid of the inflammation. But if you have a particularly joint injury or a sporting-related injury, then the inflammation is part of the healing process. So whilst ibuprofen will make you mobile and reduce your pain, it will generally prolong the healing process. So we should be very cautious about giving ibuprofen in some settings, as well as a longer-term effect of gastrointestinal problems, stomach problems, etc., which is why not many patients are on sort of long-term ibuprofen anymore. We have topical solutions. Ibuprofen and Voltarol being the most common diclofenac. A diclofenac solution is really good if you've got a sore, something, and you rub the diclofenac on it. It just makes it go numb completely. Yeah, it's really, really effective. Ibuprofen gel, not prescribed so much anymore nowadays in its weaker forms. I did go and look for it, but I couldn't find it. But there is, I'm sure someone can. There's a paper out there somewhere that did a randomized control trial of ibuprofen gel, and they actually used unlabeled tubes, some of which had ibuprofen gel in, some of which actually had a lard type substance in, because it had the same consistency and feel. They must have got rid of the smell out of it somehow, but when they rubbed it in, it felt exactly the same. So they compared these two groups, one group that had ibuprofen gel and one group that had lard rubbed into them, and they all reported the same analgesia. So it just shows the power of placebo sometimes, but also that ibuprofen gel may not be overly effective. And certainly there was a big cutback after that on it being prescribed. And then finally, things like transdermal patches, most commonly fentanyl is the one we see, isn't it? Yeah, for long-term analgesia and severe chronic pain, these patients have fentanyl patches on them. Certainly, I'm aware of a few cases of opiate overdoses where people have had fentanyl patches put on them, and people have started adding more fentanyl patches. At the prescribed time, they've replaced the fentanyl patch, but haven't taken the old one off. And the people can end up in opiate overdose through having lots of fentanyl patches on them. So if you go to an elderly person, it looks like they're high as a kite, and they have fentanyl patches, then have a quick look at their back to make sure they're not covered in fentanyl patches. And that's the reason that they're in opiate overdose. Someone's popping up some evidence there. Is that you, Andrew? Thank you. How about inhaled medications? So generally inhaled analgesia, we have two choices nowadays. Entonox, actually quite effective, often underrated. Yes, people don't give it time to work, and that might include the patient as well. Yeah, so you have to explain to people, about using it properly. It might take sort of 5 minutes plus, to reach effectiveness. But Entonox does work and is an effective medication, mostly really safe. We have to have extreme caution about people who seek analgesia. Yeah. Entonox frequent flyers, or I think I'm supposed to say regular service users nowadays. I'm aware of at least one case in the UK of a patient who was repeatedly given Entonox by an ambulance service and by the emergency department, who ended up with the effect being permanent, because the way Entonox works in blocking the signals in our nerves. If you have too much Entonox, that can become a permanent effect. And we see that now in people using nitrous as well, don't we? The nitrous abusers can end up with the same thing. They effectively end up with paralysis. So that's why there's the guidance around how much Entonox you can have over what period, etc. We also have to be very cautious about chest injuries. I think chest injuries in 𝐥𝐢𝐤𝐞 has even been sort of upgraded in recent times, from a sort of a caution towards a contraindication. You have to remember that non-tensioning pneumothoraxes are very difficult to detect. Yeah, and we could obviously exacerbate that, safe-ish pneumothorax into a tension pneumothorax. So we should be very cautious with Entonox and chest injuries. I generally won't give Entonox to anyone that I'm concerned about has a chest injury. And then more recently, of course, we have access to the infamous green whistle, or Penthrox. Yeah, they've used 50 million doses, whatever it is, in Australia, with minimal complications, and all forms of responders have access to it. Yeah, it's a good point there as well. Entonox is also very open to abuse. You can't measure what's in the cylinders, so they're very, very open to abuse because it's hard to measure. So yeah, Penthrox now has a UK license for adult trauma only, and I'm sure that will spread out over time as we have more uses of it and can prove that it's safe. We have access to it and use it, and it can be very useful. But it is very, because it's new, it's very much hyped. Yeah, how it's a panacea, and it really isn't. I've quite a bit of experience of using it now. It works well. It's quick. Yeah. Um, but it only works for a limited time. In reality, you only get about 30 minutes of decent use out of a Penthrox inhaler, and they can only have two of them maximum. So if you're a long way from hospital, working in a remote area, etc., that may not be enough. But it can be a good bridging or procedural analgesia. Yeah, if you get people to, go on it really hard, so you can, do a procedure or just while you prepare other analgesia. Definitely watch out for bystanders. I've only seen it happen once. We were using some Penthrox, and the injured person's partner kept sort of hugging them from behind and was reassuring them and doing some very nice stuff. But unbeknownst to us, was actually getting a bit more Penthrox than we thought. He wasn't breathing out through the filter like he looked like he was, and we couldn't smell it, so we didn't have any concerns. But we looked up and saw our eyes start to roll, and had to sort of help the partner to have a sit down for a minute while the Penthrox wore off. So you have to be careful about using it in confined spaces and so on, but we've not really had any major issues as long as they do follow the instructions they're given. But both can have extremes of response when used properly. Entonox works really well on some patients. They sit and laugh their head off or giggle or become completely drowsy, or not work at all. I've had the same with Penthrox. I've had patients that Penthrox does not work on. They're using it properly. They've inhaled loads of it. It has no effect on them whatsoever. Yeah, and I think that's the nature of inhaled analgesia. Yeah, the effectiveness is very variable. What we do know is neither of them is that good for the environment. Anesthesia is moving away from gas-based anesthesia like fluorines, which includes Penthrox, but it's an older one, because of its part of its environmental price, amongst other things. And for that reason, the Entonox price has climbed dramatically. I think if you look now, the cost of an Entonox cylinder refilling one is probably actually more now than Penthrox at NHS price. So I think we will see wider use of Penthrox, even though its scope currently under its license is very limited. Therefore, we're not in a position where we could have Penthrox instead of Entonox if we're dealing with a mixed patient load, because we still need Entonox for some other patients that can't have Penthrox currently, like all pediatrics, unless you have a medical director willing to use it off-label, which happens in places. Intranasal is probably the one that pre-hospitally is not, widely used, whereas in hospital is used a lot in pediatrics. And I think there's a real gap here. Now, ideally, you need the 𝐦𝐸𝐷𝐿, the mucosal atomizer device at the top there, the little foam thing that goes in and turns it into a nice mist and stops it leaking out. Remember, it can only be very small volumes. In adults, about 2 mils a nostril. Therefore, you may require higher strength medications. So diamorphine, fentanyl, high strength ketamine, as you see there, 500 milligrams in 10 mils, 50 milligrams a mil ketamine. And of course, that brings along with it the risk of drug error. If you're carrying more than one strength of a drug, there is an inherent risk. And there are a number of reported errors in the UK of the wrong strength being given, particularly as the labeling and packaging of drugs here is a bit of a free-for-all. And so you could pick up identical ampoules of different drugs. And that's, difficult. Intranasal pain relief, that'd be interesting if anyone's using that out of hospital. Certainly in hospital is used a lot. We have the atomizers. And Narcan, Narcan, I think, might even be in 𝐥𝐤𝐤𝐞 now for Narcan use intranasally. The one thing you also have to remember is the mucosal atomizer device is a great thing, but it retains about 0.6 of a mil in the atomizer, because you can see where it comes out in the syringe. Some of it will stay in the atomizer tube. Yeah, so you have to actually calculate the extra 0.6 of a mil, particularly if you're working in small doses. Yeah, for pediatrics, talking about very small amounts. But yeah, can be really useful. And it depends a bit on available circulation as well. Obviously, you've got to have the intranasal circulation. You've got to have, the membranes have got to be working. So if someone's got a nose full of gunk or whatever, it's not going to work. So if it's snot or dust or whatever it might be, it's just not going to get absorbed that well. But I think it's a place where we really, really miss out. So, it's something where we could, have a greater use. Definitely, I think even in adults, where we, need to get rapid analgesia and access isn't available, etc. It could be a very beneficial route, and we are starting to see that more and more in places. Intramuscular, again, a route that's used widely in other settings, for providing analgesia. 5-year IO is not available, particularly people that are, difficult to get access in. Could be in pediatrics, not clinically appropriate, like end-of-life care. I don't have IV lines in people. Like intranasal, due to the small volumes you could administer. I mean, currently we're guided to give intramuscular TXA if no access is available. And that's 10 mils, so 2 5-mil injections. That's a lot of fluid. We generally prefer to give much less intramuscularly because it can be painful and it may not be absorbed as quickly. So again, we may need to use higher concentration medications with that associated drug risk again. The doses may need adjusting to suit the absorption rate. So those doses again may not be familiar. And this could be morphine or diamorphine or fentanyl as a rapid acting and strong opiate, or again, ketamine, but it tends to be used in the stronger form. And as a risk then, if subsequently you gain IV or IO access, and then you have those high strength drugs around, and the risk of them being given IV or IO instead. And we know once something's in a syringe and people have access, then human nature suggests it gets pushed in. I think giving adrenaline 1 in 1,000 IV is one of the most common UK ambulance drug errors, because the stuff's in a syringe and the person's got IV access, syringe gravitates to IV. So yeah, there's a whole level of risk in there. The absorption rate is very variable and unpredictable, depending on the temperature of the patient and the level of circulation. So if they're cold and shocked, intramuscular may not be a great tool because it's unpredictable. It depends on where the drug ends up in the muscle, how vascular that area is, etc. But certainly, if you look at other studies like the intramuscular TXA study that's leading to TXA auto-injectors, which is a British military project, I believe, then they showed that I think intramuscular TXA was as effective as IV TXA within 20 minutes. So there is a place for it in certain conditions. And then, of course, our IV or IO, both equally effective, particularly if using head of humerus IO, remembering that injury or circulatory status may make tibial IO less effective. We don't always need a large bore IV for analgesia. The amount of volume we're giving, the amount of fluid is very, very small. So unless we're going to be giving a lot of fluids as well, then we can get away with very small IV access if it's just for analgesia. And looking at the medications that are available, obviously we have access to IV paracetamol. It makes people very upset because it's quite expensive compared to some, fraction of a pence tablets. And there is some studies from emergency departments that are time-based that show that IV paracetamol is no more effective than the oral dose because the amount the patient receives is fairly similar. But I think in the pre-hospital setting and in my personal experience, the IV seems to have better onset, which makes sense. Hasn't got to go through the process of being absorbed and making it to the site of analgesia, and seems to be more effective, particularly when used as an adjunct to other IV analgesia, like giving IV paracetamol and morphine, which in my experience, particularly in peripheral fractures, leads to us giving less morphine and therefore limiting the side effects of those medications. Morphine probably being the most common of UK analgesia for hospitals. Yeah, I think someone's asked there, can morphine be given IM? Yeah, absolutely. Yeah, and it's I think it's guided in 𝐥𝐤𝐤𝐞 to use it that way in patient groups where required. And morphine is widely used in UK pre-hospital care by paramedics, but it has its problems. Some patients are super sensitive to it. Occasionally, you go to a patient and give them just a smidge of morphine, and their blood pressure will plummet, or they'll vomit, or whatever. Which generally isn't, massively over concerning. Normally, it's a transient effect, and you learn not to do it again. Yeah, to that patient. Yeah, unless you change the way you give it. It could be you've given it too quickly. Yeah, whatever. It's often not really dose dependent. To hear people saying, "I'm just going to give a tiny bit of morphine to see what happens." I think if the patient is really sensitive, then a tiny bit seems to have the same effect as a bit more. And also, some patients are not naive to opiates. Yeah, and they can be ineffective or suboptimal. Yeah, if you're a chronic pain patient, and some of these patients build up through phenomenal amounts of analgesia, and we're going to a patient who was taking, about 240 milligrams of codeine, oral codeine a day. Yeah, and if someone's taking that much oral codeine, it's unlikely, 10 milligrams of IV morphine is going to do anything to them at all. Yeah. And we see that in a lot of sort of chronic, long-term chronic pain patients who've been using opiates. Remembering that opiates, are pretty much the last resort for prescribing for chronic pain because of the side effects and the addictive nature and many other things. But if patients are on, long-term opiates, then sometimes our morphine may be completely ineffective, just doesn't touch the patient at all. They're so used to having opiates in their system. The other alternatives, fentanyl, a stronger, faster acting opiate, but unfortunately, paramedics in the UK can't possess fentanyl because of the drug classification it has, even though in other countries it's widely used in ambulance services across Europe and the US as a complete alternative to morphine. They have fentanyl instead of morphine. And I think we probably would here if there wasn't this drug restriction in place, which really comes from the time when fentanyl really was only a drug of abuse. So we probably need to get that changed so we could use fentanyl more. It's certainly much quicker acting. Yeah, so someone saying they're using the Netherlands is pretty much standard in many other European countries to use fentanyl. Yeah, remembering the peak effect of morphine is 20 minutes. And that's not an ideal pre-hospital medication if you've got to wait 20 minutes to find out if it's really worked properly or not. Some of the requests we get for providing extra analgesia when a patient's had morphine, actually, by the time we get there, the patient is absolutely fine. It just needed that bit of time. But of course, that's unpredictable. Yeah, so to ask for help was absolutely the right thing to do. But actually, remember, the peak effect of morphine is some way off. Fentanyl doesn't have that issue. And again, ketamine, widely used by enhanced care and critical care teams. But, again, in other countries, widely used by paramedic ambulance crews. And, the Pac-Man trial there, which ran across West Midlands and I think somewhere else, maybe Yorkshire or somewhere, compared ketamine and morphine in trauma. So I think they could either give 10 of each. They could either give 10 of morphine or 10 of ketamine to trauma patients. So a relatively small, safe dose of ketamine. Was being used by ambulance crews. And I think there is a future in there somewhere of alternative analgesia options for ambulance crews where morphine isn't the ideal agent, particularly in patients that are hypotensive. Someone saying 10 milligrams of morphine or 15 milligrams of ketamine. Was that the Pac-Man trial? So that's ideal. To never forget our multimodal analgesia, adding differing types to achieve the pain score goal is good practice. Yeah. The way that analgesia is done in primary care is you start the patient on low-grade analgesic and you add stuff on. You don't necessarily take the other one away. So if you're giving someone Entonox and it's not enough and they give them some morphine, you haven't necessarily got to take the Entonox away. If they stay on the Entonox and you can add some morphine on top, then you might get the analgesic effect you want without the side effects of the opiate so much. Yeah, so never forget that, using multiple layers of analgesia can be very effective. So do we miss our target with analgesia pre-hospitally? I think certainly in the UK we have some issues. We have wide gaps in what we can provide to certain patient groups. Yeah. And in certain conditions and what certain patients will tolerate, etc. I think particularly around the speed of analgesia we can provide, where some of the stuff we have is very slow acting, and the provision of analgesia to pediatrics, where we know we have, some issues, particularly in some services where they have very limited options for oral analgesia, and they're just left with probably Entonox and morphine if that's permitted in their service. So there's a lot we can take away, I think. Look out for our next webinar. So our next webinar is about, how can I assist with the pre-hospital emergency anesthesia? If you're not part of a critical care team, how can you be a really useful assistant? What knowledge would be really useful to you to know so you can be the best assistant you can be when a patient is receiving a pre-hospital emergency anesthesia? The critical care teams often just come as a team of two. And while that, so the more help they can get, the better, the smoother it will go, the safer it will be, etc. So we're going to look at that in our next webinar and look at the CPDme app or website to find out when that is and how you can sign up for that. I think there's a future date to be planned in the coming week, so look out for that one. So many thanks, everyone.